Thank you so much, sir.
Good afternoon to you all. I welcome you all to this scientific particular case and expertise that is being shared with you. So, sorry, go to the slide. So, first of all, I will just tell you what this patient is. The first slide, please. So, we had a lady, about 35-year-old, from a foreign country. Please go back. Shall I? Next slide. Yeah, a 35-year-old lady from a foreign national. She has a busy social and official life, and I mean to say that she's a lawyer as well as a diplomat. She had a 2-year history of mild facial weakness and hearing loss. So she had a lot of evaluation of this particular condition throughout the world, I would say. When she came to me, she had investigations and opinions from almost half the part of the world, the Europe, the Middle East, etc. So the patient have diagnosed as a case of facial nerve schwannoma. Now, before I go further into facial nerve schwannoma, I will try and tell you, explain to you what is this facial nerve and what is the facial nerve schwannoma is. Because if you don't understand that particular aspect, maybe you lose the context. Next. So facial nerve is a nerve which actually supplies the face. So there's a nerve from the brain which comes, supplies one half of the face, both sides. So everything that you move, that you speak, when you smile, when you close your eyes, this is a nerve that helps you do it. So any weakness in this nerve leads to weakness of one side of the face. So you can understand the gravity of situation when a nerve, these kind of nerves are involved, facial nerves involved in a patient, because the patient can't even look outside and finds one side of the face weakened. Just to show you in this photograph, you can see I'm trying to take a little bit into the ear. That is the ear. It has the ear canal and then the eardrum. After that, there are small bones called the ossicles which actually transmit the sound, and then you have the inner ear where the nerve is there. Next slide. The facial nerve is the only nerve among all other nerves called the cranial nerves which exit from the brain and come into the neck. This nerve has a peculiar fashion. It goes through a bony canal through the ear. It goes through multiple areas. So you can see the yellow line that is shown there. It goes in between the balance area, the hearing area of the ear. It goes next to the ossicles and then comes out through the skull base. Next. So the yellow photograph that has been shown here is the facial nerve. When you look at the photo, the round thing is the tympanic membrane, those two small ossicles there and the facial nerve around it. You may also come to know that few millimeter above are the canals for the balance and a few millimeter below are the canals for the hearing. So it's in a compact area with everything around it. The ossicles, which are the bones for hearing, the nerve for hearing below it, and the balance. Next. So just magnifying that previous one to this level, we find that that yellow nerve, those two are the ossicles, those two bones that you see are the ossicles, and that is the yellow is a nerve called the facial nerve. The LSCC that is written, that is actually the vestibule or the balance area. And all this is just a millimeter above and below. The next slide. So the red area was the facial nerve schwannoma. In this particular case, you can understand where this particular schwannoma is sitting. That's why I try to take you through multiple slides to make you understand. It's not a 10 kg tumor, but it's in an area which is a millimeter away from the hearing, the nerve to hearing. So structural outcome is how good the structure was. Can you just play the video? So that video just shows a normal ear. This is just to give you an idea how if I put an endoscope into the ear, that would be the tympanic membrane. That is the eardrum. This is a normal one. Just to give you an idea. So, next slide please. Next slide. Yeah. So this on the left that you see is the endoscopic of this patient after surgery. The membrane is almost as good as normal. Whereas if you had performed a microscopic surgery, on the right side would be what with the condition? It would be a huge cavity. We call it a cavity because the bone is all removed. And this patient will have this kind of cavity throughout the life. Some amount of discharge happening throughout the life. There is no actual membrane in the ear. There are no ossicles in the ear. So structural outcome, we say we almost same back to normal. This patient can go and take a swim. Water goes in the ear, nothing is going to happen. But if the other patient with the cavity cannot go anywhere near taking a bath properly, because always has to keep the ear blocked. Next. The next functional outcome when we come to is the ossicles are all preserved in this case. There is no cavity, so we get excellent hearing restoration. That is one of the things that she wanted. I want to have a good hearing. So hearing restoration is actually an audiogram of the patient after surgery after about 8 days. It's almost normal. Next. Most importantly, quality of life. Definitely, as you would see, there's no scar, there's no shaving, there's no bandage. Better cosmesis. We actually discharge the patient within 12 hours. A faster recovery because there are no major cuts in the body. Early return to daily activities. Most of these patients that we perform, even this lady, could get back to normal daily activities. No mastoid bandage. Normally a ear surgery, I'm sure many of you heard, patient is roaming around 1 week with a mastoid, with a bandage around the ear. We didn't give her a bandage at all because there were no cuts. No interventions during flight travel, especially in this lady, she wanted to go back within 7 to 10 days. So no interventions in flight travel, and she could perform all recreational activities. So how did we get about doing this? The next slide. Yeah. So we followed 3 principles. We were talking about 3 principles. So the first principle, oncological surgery. There has been no leeway or anything being done to take out the oncological principles. That means if there's a tumor or cancer, it needs to be removed. You can't say because I'm doing a minimally work and I will just remove part of it, leave a part of it. No. So oncological principles were followed and the complete removal was performed on this. Also, I have a lot of expertise in lateral skull-based surgery because there are tumors coming out of the skull in this area. So we know how the tumor behaves and how it travels. And finally, advanced endoscopic ear surgery skills. Using advanced endoscopic ear surgery. For example, we do perform endoscopic ear surgery for a basic thing like an ear perforation. But then these are advanced stages where we are doing for various tumors, and especially in this case, the facial nerve schwannoma. These advanced endoscopic ear surgery skills have been developed over years, and we have various publications on this. Next. So we have these publications of our a large number of series of cases that we have performed with endoscopic ear, with the endoscope. Next. Next, we performed surgeries, things like cholesteatoma, which are actually diseases which can erode the bone and cause complications. And finally, the next publication will show, next, excision of a tympanic paraganglioma. So 4 years back, I don't know if any of you have heard something called a glomus tumor, a very vascular tumor in the ear. Again, the surgery is an open surgery, open youth surgery, tumors in the ear. So 4 years back when we did the first endoscopic tympanic paraganglioma, we were the first one who did it in this country. So there were about 10 cases described in the literature in the world. We were the first to perform it. Since then, we have performed 6 cases.
Good afternoon to all of you, my friends. But first and foremost, Dr. Satish Nair, Senior Consultant, ENT and Head and Neck Surgery at Apollo Hospital, Kannada Road, Dr. Savit and Dr. Asha. I welcome you, and it's a privilege to have you here with us. And you'll take us through what a breakthrough procedure we've been able to operate on, or we've been able to accomplish at Apollo Hospital's Cancer Center, Banagata Road. But before I hand it over to Dr. Nair, I just want to kind of set the context a little bit to give you an introduction. While Apollo needs no introduction, but we are the largest, it is the largest private healthcare chain in the country, but also runs the largest cancer center network in the country. We have about 14 cancer centers spread across different cities in the country, about 1100 beds. And being privileged, we have the privilege to have about 250 oncologists who are employed at these cancer centers and deliver great cancer care day in and day out. At Apollo hospitals, and besides these centers, Apollo network, cancer network, has many firsts to its credit, and the most important and most prominent, I think, in the recent years has been setting up the first pencil beam proton therapy unit at Chennai, which is the first of its kind in South Asia and Middle East. We've been a couple of years into inception and really delivering great care to patients from 147 countries. At Apollo Hospitals, Banagata Road, again, several firsts to our credit. It was among the first few cancer centers in the state. The cancer center had the first brachytherapy unit installation. It was the first center to introduce Novalis technique, the first center to introduce true beam STX.
This case. However, like I said, it's like almost a year later that we would like to do a MRI or a contrast evaluation of this particular thing, if anything is coming back or not. But the chances are very minimal.
Yes, that is the follow-up.
That is the follow-up.
This is the first time in India, sir?
This is the first time transcanal removal of facial schwannoma in the world. There's no other public research. The other thing I was talking about is that glomus tumors, which 4 years back which we performed, that was the first time in India. There were multiple other such tumors performed in the world before that.
Doctor, if it is allowed further, what will happen?
So if it grows further, for example, I have also had an opportunity in last year to operate 2 huge facial nerve schwannomas. These facial nerve schwannomas came as swelling in the cheek. They were so big, 8 into 7 centimeters. So they grew from brain onwards through the ear and had come out into the cheek. We call them giant facial nerve schwannomas. So what they had done, they had broken everything on the way. So they had ensured all the ossicles were gone, the hearing was gone, the inner ear, the nerve, everything was pressed, and the hearing was lost. So once they start growing, they start, weakness of the face is definitely there, but in addition, it also takes other things around it and starts applying pressure.
Doctor, what are the reasons for this? And if a person takes healthy food, is it linked to this or?
Actually, this is a very sporadic tumor. There is no particular cause for developing a facial nerve schwannoma. Like other schwannomas and other nerves also, they may just develop in a person.
It can happen to anybody at any time.
It is rare, but it can happen.
Is it any specific age category you found the patient?
Normally, schwannomas we could talk about in the 4th to 6th decade, that means 40 to 60 years of age. This lady was at 35 years of age, so a little earlier.
Doctor, there is a question from Financial Express. I'm just reading it out to you. This is from Ms. Shushmita Panda. So what she is asking is, what is the...
Hello. Dr. Asha, Professor and Senior Consultant, Anesthesiology. Her areas of interest are neuro and skull-face anesthesia along with pediatric anesthesiology. And we have with us Dr. Savit Kumar, expert in neurovascular interventional radiology. And I also take this pleasure, immense pleasure, to greet all the media personnel and with my great gratitude for accepting the press invite. So may I invite all the dignitaries on the dais.
General anesthesia using what is called as laryngeal mask airway, which so that we had planned it as a daycare procedure so that she can get back to her daily functions as soon as possible. And we gave controlled hypotension so that he could operate, because as he told that it's in a very, very small area. Even if a small RBC comes out also, it will be like it will be a disturbance for them to operate. So basically administering anesthesia is to keep the patient comfortable as well as the surgeon so that they can go ahead. That actually helps in reducing the duration of the surgery. Otherwise, if it keeps bleeding, then there will be a problem. They will not be able to visualize the structure and with minimal space available there to operate. And of course, at the end of the procedure, we had to give good pain relief so that she can go home and get back to her work.
My next question was that what about the pain aspect? Is it post-operation?
So again, as we are cutting less tissues, the skin is not cut, bones are not drilled. So and like I said, we almost did like a daycare surgery. So the pain is very minimal. Definitely there would be some soreness in the ear that the patient feels, but there's no actual pain.
Doctor, there's one more question from our media who has.
We performed the first time in the world a transcanal endoscopic excision of facial nerve schwannoma. The facial nerve schwannomas are tumors that are present in an intricate area inside the ear. So there was this patient who had this tumor for a couple of years and had developed various symptoms with it. As the patient wanted a minimally invasive technique, we went about performing the surgery by an endoscopic technique through the ear. There were no scars or drilling of the bone performed. There were no bandages after surgery. The complete schwannoma was removed through the canal with an endoscope with excellent results.
How much time it took and the whole process?
Yeah. So the surgical process completely took about 2 hours, excluding the anesthesia. The patient, the facial nerve tumor was removed through the ear with an endoscope and was also reconstructed with a nerve, placing all the ossicles and all structures back. The complete hearing was restored and the facial function has started. Yes.